from anemia, from volume depletion, or much of it is simply from biorhythms. In other words, as we spoke about a couple weeks ago, your hands are a little colder one moment, your skin is a little more flushed, your bowels are a little looser, your bowels are a little tight. There are biorhythms. You have to explain that concept to patients because very often patients will get extra beats or any arrhythmias, which we'll talk about. And it's the frightening thing about arrhythmias is the unpredictable nature of them. And people assume that something is wrong if they got an arrhythmia at a time when they just didn't expect it. They were doing the same thing they did a minute before or a minute later. Why did the arrhythmia occur that moment? You have to get across the idea of intrinsic biorhythms. I use the analogy of the menstrual cycle because most people get the idea that the menstrual cycle is the epitome of intrinsic biorhythms. And it's the same thing with sympathetic inputs, right? Hands are colder, skin's more flushed, bowels are looser, etc. So you have to get that across to people. But the sensation of premature beats or an extra beat is caused generally from enhanced sympathetic tone and facilitated sodium entry, so that can occur in the atrium or it can occur in the ventricle. That's point one. Essentially, all important human arrhythmias occur via the mechanism of reentry. So you have to understand reentry, and the most important concept is that the arrhythmia that you have depends on what chamber the reentry occurs in. If it occurs in the atrium, you have a circuit in the atrium called intraatrial reentry, the most common of which is called atrial flutter. If it occurs in the ventricle, you have intraventricular reentry called ventricular tachycardia. If it occurs within the AV node, you have what's called AV nodal reentry, which is a common arrhythmia in healthy people. We'll go through that step by step. So you have to understand reentry. So let us say that reentry occurs anytime there are two adjacent pathways that are electrically different. That can be an inborn pathway in the AV node or an acquired pathway from muscle-rendered heterogeneous fiber to fiber. So let us say that I have mitral stenosis and I stretch the atrium. Or I have heart failure from a weak left ventricle and I stretch the atrium. Stretch can impose a difference in electrical properties from one fiber to another fiber to its neighbor in the atrium. If I have a heart attack or a cardiomyopathy or anything that injures the ventricle, one muscle fiber can be electrically different from its neighbor. That is what generates reentry. So in order to get it, I need two adjacent muscle fibers that are electrically different. We will label one A and one B. And they have to have a certain property. A has to have the property, and these are relative properties, one to another. A has to have the property of rapid conduction, but a long refractory period. It just takes longer to recover the capacity to conduct electricity. We will assign fiber B the property of slow conduction, but a short refractory period relative to A. So what happens if I get a premature beat? Let us say this is within the atrium. If I get a premature atrial beat, we spoke a moment ago about how that can occur. I'm a little bit nervous. I have some caffeine. I'm a little bit overstimulated. I get an atrial premature beat. What if it comes at a time when which fiber would be refractory longer? We said A would be refractory longer, so the impulse would go down which fiber? The fiber with the shorter refractory period, right? So it would go down fiber B, right? A is still refractory, so the impulse will go down fiber B. If it zips down fiber B, nothing can happen because A is still refractory. But if we assign B the additional property of slow conduction, by the time the impulse gets down here, A is recovered, and the impulse can go back A and start a circuit called reentry. You have to understand that because that's the mechanism, essentially, of all important human arrhythmias. Heterogeneity has to be created from one fiber to its neighbor in such a way that these properties are fulfilled. That makes sense? Yes? Okay. So I can get this in any area of the heart. Let us say these are my three structures: my atrium, my AV node, and my ventricle. So let us say that something stretches my atrium. Anything, mitral valve disease, left ventricular stiffness, left ventricular weakness, anything that stretches an atrium can create an A and a B in the atrium. And if it creates an A and a B in the atrium, it will initiate, if I have a properly timed premature beat, it will initiate intraatrial reentry. Right? I need that premature beat to come at just the right time when one fiber is still refractory and the other has recovered. If it comes too early, after the beat before, both A and B will be refractory. If it comes very late, both A and B will have recovered. I need a beat that comes at just the right time to find one not yet recovered to conduct the impulse and its neighbor able to. Make sense? Okay. If that occurs within an atrium, I get a rhythm. You can call it intraatrial reentry, or you can call it atrial flutter. Atrial flutter is a term that encompasses the most common site of reentry in an atrium. Happens to be at the bottom of the right atrium. That's a detail. There are thousands of potential circuits that can form in an atrium. We will stick with the most common one, which is called atrial flutter. Atrial flutter is intraatrial reentry. Now, the way atria are created, the conduction velocity in atria is such that, there's no way to know this, this is just kind of how it is. The conduction velocity of atrial muscle is such that when a circuit occurs, it goes somewhere between 250 and 300 times a minute. So when I get intraatrial reentry, this circuit becomes the battery that makes the atria contract. So every time the circuit comes around, its wavefront spreads to depolarize the atria. Instead of the atria being depolarized from the sinus node, which is firing, this becomes the generator of atrial electricity. And the way atria are comprised, the way God made atria, if you want to go there, the bottom line is then intraatrial reentry is at this rate. So if I have atrial flutter, what I will see on my electrocardiogram is a P wave rate of 250 to 300 beats a minute. The reason it is important to know what rates are characteristic of each chamber is that's how you will define what rhythm the patient has. Because as we will see, different areas in the heart have different conduction velocities. But if I see a P wave rate at 250 to 350, I know that that reentry is occurring within atrial muscle. And when I want to treat the patient, I will then have choices, but they will involve the understanding. Am I getting arrested or? You will then have a choice of how to treat the patient, and we'll talk about that in a moment, but it will all be based on the understanding that this circuit is in the atrium, right? Okay. How about the AV node? The AV node's a little different because the heterogeneity, the AV node doesn't get diseased by any acquired disease. Do any of you guys have a symptom where you suddenly, out of nowhere, get a rapid heartbeat? Anybody have that? You have that. Okay, can you describe what that is, what that feels like?
It just feels like heart's racing.
Boom, sudden onset, boom, sudden offset, yeah? Like a switch on, switch off, right? If you were just nervous, if that were just increased automaticity of the sinus node, it would be gradual onset, gradual offset. So when you're trying to figure out, when a patient says, my heart beats fast sometimes, and you want to know, is it the engagement of a re-entry circuit and the termination of a circuit? You will ask that patient, is it sudden on, sudden off, in which case it's re-entry, it's an arrhythmia. If the patient says, nah, it comes on gradually when I'm nervous and slows down gradually, you will assume it's just sympathetically facilitated augmentation of sinus node automaticity, yeah? That make sense? So yours, do you know how fast it goes when it occurs? Give or take? So, for example, I have, as about 1 in 10 people have, and it sounds like you have, especially cool, great people. It's, normally, you have one pathway in the AV node. About 1 in 10 people have 2 pathways, what's called dual AV nodal pathways. That's not acquired, that's inborn. And so, for example, I get about every 3 or 4 months, I like to run. I run in the mornings. If I've had too much red wine, if I'm a little sleep deprived, if my engine is just at a certain level, when I run, I get that symptom. Boom, all of a sudden starts, I get a little dizzy, I take my pulse, it's about 190 beats a minute. So what's going on with me? What's going on with me is I have an atrial premature beat from enhanced sympathetic tone. It finds one of these pathways refractory, goes down the other, and starts re-entry in the AV node. Same thing. Now this becomes my battery that drives the ventricle. If that's the case, the P wave rate, it also goes back and depolarizes the atrium backwards, so I can identify it by a P wave rate of 150 to 250. So if I have an arrhythmia at that rate, I will assume it is AV node re-entry. And the reason that's important is there are different medicines, different strategies to treat that rhythm versus intra-atrial re-entry, which is atrial flutter. Make sense? Now, what will both of these rhythms look like when they occur? And my question is, will they be narrow, complex, just like every normal beat, or will they be very wide? Well, they'll look fast. The ventricular complex will be fast because the ventricle is being driven by that rapid circuit above it. But the ventricle will be activated via the normal conduction system. So the QRS will be fast, but it will look just like every beat, right? Because the beats are originating above the ventricle, so it will go down the bundle of His and the bundle branches just like normal beats. The lingo for that, since normal beats are narrow, the lingo for this, for anything above the ventricle, is called a narrow complex, meaning a narrow QRS tachycardia. Yeah? Make sense? Okay. The third place that re-entry can occur is in the ventricle. From prior heart attack, cardiomyopathy from alcohol, from burnt out aortic or mitral valve disease, anything that stretches or injures a ventricle will create this heterogeneity in a ventricle. So let's say somebody had a heart attack a year ago. This area is injured. If I develop re-entry in this area, in the ventricle, it will be a tachycardia, same thing. Each time the circuit goes around, the wavefront activates the ventricle. Each time it goes around, wavefront activates the ventricle. And that's called ventricular tachycardia. Ventricular tachycardia, the QRS is about 150 to 250. In other words, the ventricular rate is about 150 to 250. How will I identify that as opposed to any of the rhythms occurring above the ventricle? What will ventricular tachycardia look like? Will it look like the normal QRS? No, because this circuit is in some weirdo spot in the muscle, and it will take me time to depolarize the ventricle because I am not using the very specialized, rapidly conducting His-Purkinje network, right? The reason that the normal QRS complex is narrow, right? The EKG is a timeline. The reason it's narrow is that I get to the muscle through this very rapidly conducting His-Purkinje system. So the muscle, the time it takes for the muscle itself to be activated is very short, because it's all via very specialized conduction tissue. In contrast, if I start a circuit in some weirdo place in muscle that's been injured or rendered heterogeneous, it takes time for that circuit to depolarize the ventricle because it's going through muscle, which is not specialized. Therefore, it takes longer. So the complex, the QRS complex, will be wide and look very different. So ventricular tachycardia looks very different. It is a wide complex tachycardia. We will see some examples of this, but instead of it being very narrow, it is a wide complex tachycardia. Very wide and bizarre, will look very different than the normal beats. Yes, sir?
Why would it just conduct through the bundle of his from that tissue?
From what, I'm sorry?
From that muscle tissue? Why would
Well, so, I mean, it's a good question. Why doesn't it conduct through the bundle of His? Because the bundle of His is up here, right? This is the bundle of His as it's entering the ventricle and leading to the bundle branch system. This is in some weirdo spot. It may eventually join the conduction system, it may, but it's going to start conducting through muscle, and it's going to take a long time for that to happen. Yeah? So it's going to be wide complex, yeah? Other questions? Yes?
Can you explain why the P rate in AV reentry is 150 to 250?
Very good question, because the circuit is here and it goes backwards and activates the atrium and ventricle. So the P wave rate is the rate of this circuit, which is 150 to 250. This is just how AV nodes are made. I used to say, this is how God made AV nodes. And then last year after the lecture, I got a very angry email from somebody that said I shouldn't put God in the lectures. I'm sorry. So I'm very serious about this. If I offend anyone, forgive me. I'm saying it demonstratively, not as a... But that's how we make, that's how the system is comprised, right? An AV node, the way it is that's the intrinsic conduction velocity of AV nodes. Right? Okay. So this all makes sense. And what rhythm you have is simply based on what the P wave rate is in each of these rhythms. And ventricular tachycardia is very wide. Ventricular tachycardia you're not going to identify by a P wave rate. You're going to identify it by a fast, wide tachycardia, because the P waves are irrelevant to ventricular tachycardia. The P waves are going to be doing their own thing. They're going to be dissociated, have nothing to do with the ventricle. So ventricular tachycardia you're going to identify because it's a fast, wide tachycardia. Yeah? Yes, sir?
Do you have, in the case of ventricular tachycardia, in addition to that circuit, a functional Purkinje network? Or is it shot?
You do, but it sits there.
Okay, so it's not being
It might get some conduction backwards from that circuit, but that's not important. The important thing is the thing that generates the impulse is this circuit somewhere in some weird place in the ventricle. because
The
it takes
SA node
time.
isn't doing anything.
SA node probably is firing on its own,
Okay,
but it's irrelevant.
okay.
The rhythm is governed by this fast battery thing, right? Okay, so let's talk about some cousin rhythms of this. So, rhythms that come from within the atrium, the prototype reentry is atrial flutter. If the areas around that circuit develop little A's and B's, the circuit will not stay as one circuit. If I create or have heterogeneity outside that circuit, so there's an A and a B here, it will, as it comes around, find this refractory and this able to accept it, and it'll start a little circuit here. If there's enough heterogeneity that there's an A and a B here, so as it comes around, this is still refractory and this can accept it, it will start an A and a B here. And if I have a lot of heterogeneity, imposed either by the structure of that muscle or superimposed sympathetic and vagal tone, right? What does vagal tone do? It slows conduction, prolongs refractory periods. What does sympathetic tone do? It revs conduction, shortens refractory periods. So you can imagine that the development of these circuits depends partly on the fixed substrate and partly on what my sympathetic and vagal inputs are, fiber to fiber. Yeah? So if I create heterogeneity around this circuit, the circuit disperses into thousands of little fibrillating wavefronts, and that's called atrial fibrillation. Then there is no organized P-wave activity. It looks like a random fibrillating baseline because the atria is activated by these thousands little fibrillating wavefronts. Yes? That is the standard model of atrial fibrillation. When you enter the clinics, you will see that there is and Dr. Larry Chinitz, who's one of the electrophysiology docs, will talk to you about this, I think early next week, about the mechanism of atrial fibrillation in young, healthy people. Do any of you guys, well, we won't go there. Healthy young people sometimes have atrial fibrillation. They have no heart disease, they're perfectly healthy, but they have electrically active areas in the pulmonary veins leading to the left atrium. These areas should not be electrically active, but they can be. And I tell you this more parenthetically, not to understand the arrhythmias, but you will see the technique of catheter ablation used very often. Catheter ablation is a wonderful technique to cauterize any circuit. We're going to talk about the medications to do this, but for example, what you can do if I have a single circuit that conducts and I want to get rid of it, I can pass a catheter into the right atrium and cauterize this pathway, this circuit. If I cauterize it, the circuit can't continue. My rhythm of AV node reentry, if I pass a catheter and I cauterize either of these pathways, the rhythm is gone. So that is a potential treatment for any rhythm that is a circuit. Atrial fibrillation in young healthy people comes from increased automaticity in the pulmonary veins. Since atrial fibrillation is thousands of little fibrillating wavefronts, I can't cauterize 1,000 wavefronts. I can cauterize the orifices of the 4 pulmonary veins so those impulses do not escape electrically and bombard the atrium and put the atrium into atrial fibrillation. Maybe I should not even have mentioned that. You will see when you enter the clinics, you will see a lot of catheter ablation procedures being done. So I just mentioned that parenthetically. That's not, maybe I shouldn't have, that's part of the treatment of arrhythmias. let's put that aside. So it is clear that a cousin of intra-atrial reentry is atrial fibrillation. How about in the ventricle? If you look at somebody, let us say that I am, as I'm walking across here, all of a sudden I drop dead. What will I have died of? Ventricular fibrillation, right? What causes ventricular fibrillation? What causes sudden cardiac death? It is something that causes, like atrial flutter became atrial fibrillation, it is usually a prior injury, ventricular tachycardia, that just like atrial flutter found thousands of A's and B's around it, it's same thing that occurs in the ventricle. So that from this circuit, as it comes around, it says, there's a fiber here that is refractory, but its neighbor can accept the impulse. Re-entry here, fiber here that is refractory, this can accept it, and it disperses into thousands of fibrillating wavefronts in the ventricle, and that is ventricular fibrillation. So most people that die suddenly have an old area of injury in the muscle. In the ventricle, ventricular fibrillation, in contrast to atrial fibrillation, the ventricle is richly supplied by the coronary arteries. So let us say that as I'm walking along here, I suddenly get chest discomfort. Conceptually, one of my coronary plaques, we said they can behave like pimples, pops. The blood flowing by tries to heal it, obstructs flow. What does ischemia, acute coronary ischemia, do to the electrical properties of muscle? It slows conduction, prolongs refractory periods. Actually, very acute ischemia in the first minute can actually speed conduction, but after that it slows it. That's a detail. The point is acute electrical heterogeneity imposed by acute coronary occlusion. Can that create an A and a B? Absolutely. And if I have a lot of heterogeneity around the A and the B, I develop thousands of fibrillating wavefronts. So if you take 100 people that have sudden death, about 70% will have an old heart attack, and something at that moment created the condition for re-entry. I had a premature beat, came at just the right time, found the circumstance for re-entry to occur. Yeah. And so about 70% will have had an old heart attack, about 30% will have an acute blockage of a coronary artery, but either can cause ventricular fibrillation. That make sense? Yes? Okay. So let's take a couple of these arrhythmias. So let us say that you have re-entry within the atrium. So I have atrial flutter. Atrial rate 300. Do I want those 300 impulses to get down to my ventricle? Obviously not. So we have a filter, the AV node. The purpose of the AV node is to filter rapid atrial impulses. And the number of impulses that it will filter will depend on its refractory period. Right?